don't worry too much about taking notes. We will send this. We'll send the slides to you as well. Thank you for attending our Newham and Waltham Forest webinar today. The session will be run by myself, I'm Pritt Kallah, for those who don't know me, and my colleague Billie-Jo, as well as Dr. Asad Ashraf, who's a GP in Waltham Forest. The session will be recorded, as I've always said, and the presentation slides and any frequently asked questions will be sent to attendees afterwards, as well as the feedback form. Please could we ask you to complete this and return it to us, as your feedback will help inform future sessions. There will be a time for question and answers at the end of each section, but you can also add anything you think of during the presentation to the chat, which will be monitored. Okay, I'm going to turn our camera off now as well. So the agenda for today looks like this. We have a section on childhood immunisations, end of life, high intensity users, wound management, and the Tea Today programme. I know we advertise the vulnerable children and the care closer to home programmes too, but because these are very clinical, we're going to cover those in a separate Waltham Forest only webinar, so we can devote more time to them. I'm going to pass you over to Dr. Asad, who's going to talk us through the childhood immunisations indicators.
Thanks, Pritt. Before we go through childhood IMS, can we just go back a slide so I can update both Waltham Forest and Newham where we are from an LMC perspective on the specs? Back onto the agenda, please. We go, yeah. So just as an FYI, the childhood IMS spec has been signed off by LMC, as has the end of life and high intensity users. The wound management for Newham and Waltham Forest differs slightly. For Waltham Forest, wound management hasn't officially been signed off yet, so there's still a little bit of work to do, but we'll still go through the spec and the requirements. The Tea Today spec has been signed off for Newham. It's approved. It's not LMC approved for Waltham Forest, as it hasn't been seen by any of the Waltham Forest LMC, but that is a national spec. So just thought I'd give you the heads up there. With regards to vulnerable children spec for Waltham Forest, that has not been signed off by the LMC yet, and feedback has gone back to the ICB. And finally, the care closer to home specs have been signed off by the LMC. I will send out an email to all Waltham Forest practices to let them know of the updates from there. So moving on to childhood IMS, if we can go to the next slide. This slide is essentially just an overview of the QOF requirements that I'm sure all practices are currently aware of. The national contract has obviously rolled over for the next 12 months, and unfortunately there doesn't seem to be much difference in scope with regards to achievements and payments. So if you've previously struggled in these domains, and that problem still is likely to occur. The achievement at QOF obviously changed last year, where they lessened the lower threshold to 89% and 86% in 001 and 002, and in 003 it's at 81% for the lower threshold payment. Next slide, please. So with this in mind, obviously the LMC and ICB had negotiations as to how we can increase the uptake of immunisations within North East London, as we are one of the lower achievement areas nationally. So some of your KPI funds that was previously used for access have been recycled to uplift this spec. So obviously they've used the JCVI guidance as well as the Department of Health guidance for children. Next slide, please. So essentially the KPI is worth a total of £2 per patient, per weighted patient. Probably the last slide is most useful for practices if you haven't read the spec yet. Essentially, you need to do what you're doing right now with regards to call and recall for your childhood immunisations for your patients. And once you've got to a point where you feel that a specific patient has had the minimum 3 recalls, or 2 recalls is national, but for the spec it's stated as 3, you need to identify these patients and forward them onto your local immunisation lead, which is in Waltham Forest is with the Federation. The exception reporting is done by the Federation themselves, so not by a practice initially. So if you, for instance, got a patient, you've called them, written to them, sent them a text message, or had a consultation with them where the parents declined the immunisation, you need to inform them that they will be referred to the borough immunisation coordinator. The borough immunisation coordinator would then make further attempts of having a consultation and trying to advise them of the benefits of immunisation. The outcomes will then be sent back to the practice as to whether or not it's a decline, or if they cannot contact the patient, or if the patient has joined in practice in last quarter. These patients can be declined and the codes will be on the template, and this will allow a payment to practices of £2 per weighted patient. The idea is that this will help support the loss of income within QOF. There is a tool that we can use at practices, so alongside your normal QOF searches, and the APL tool that's designed by KEG is a really useful tool. It's highlighted here with regards to how to use it. If you don't know how to use it, speak to your local KEG coordinator. You can filter out for all the declines that you've got at your practice, and what you're able to do with this is actually pull it out as a CSV file, so it says the export to ACRX, and be able to call these patients in automatically. You'll also be able to export this list and send it to your local IMS coordinator quite easily as well. So the childhood IMS in a nutshell is quite straightforward in allowing practices to achieve that £2 per weighted patient payment. Thanks, Britt. Any questions, please put it in the chat or raise your hands. Can't see any questions there, Pritt. Do you want to move on to who is the IMS coordinator for Newham and Waltham Forest based? I don't know that one. I'll try and find out. If anyone does know, please put it into the chat. But do you know, or Faye, do you know who the Newham coordinator is?
I'm not aware of who is for Newham, but we can definitely find out and get back to everyone.
Perfect. For Waltham Forest, Toyin, as I said, it's the IMS coordinators are held by Waltham Forest Federation. So you essentially just need to email them. The email address is actually on the spec. So I believe the ICB are going to be sending all these specs out again now that they've been signed off. So all the contact information, even for the new one, should be on the spec. But we'll try and find out and let you know. And Pat is going to do that as well. New childhood IMS searches are not up yet. So again, they need to be up with regards to EMIS QOF stuff that normally comes by the end of April. Same with System 1. Can't see any further questions. If we want to move on to end of life. Oh, sorry, there are further questions. So Imran's put, do we know how long Federation takes to do their part and then inform the GP of the outcome, as we will need to decline the patient by the deadline? So Imran, we're working with Shiraz and Federation to make sure that we get timely feedback. The best thing to do is not wait till the end of the year and send them a whole list. It's actually once you've done that coordination of the patient to make sure you feedback on time and refer that patient accordingly. What I would do for Waltham Forest is try and get an update at the transformation meetings from the IMS coordinators, how they want this organised. Thanks, Fatima. Will KEG not give searches? So some of the QOF searches are the baseline of this. So once QOF is updated, making sure there's no errors, that's what's going to allow us to run the search. So this is based off the QOF data as well. Hoping that's the last of that questions. Rick, shall I hand over to whoever's doing end of life? I'm not sure if you're there or if you're on mute. Hey, do you know who's doing end of life?
I said apologies. Yes, sorry, yeah. I don't know how it was muted. Apologies, I'll start again. So I'm going to take you through the end of life programme. Now, for this, practices need to use a tool called the Early Identification Tool, which is available both in EMIS and System 1. The tool has been created to identify patients in the last years of life, but aren't already showing on your palliative care registers. Just to let you know, this is not a CEG tool, but we are hosting this for the practices. And also, please don't confuse this tool with our Apple tools, which we do develop. So once you have a list of patients, you need to validate your list, but also use that to offer personalised care and to support discussions for patients identified by it. And the tool has actually been based on the gold standard framework proactive identification guidance and supportive palliative care indicators tool. So as I said, practices will need to run the tool quarterly and to review all the patients on the list. Now, to do that, so once you've done that, you will receive a payment of £300, and that's £300 every quarter. If you agree with the patients identified, you need to add them to your palliative care register in the care record. If there are any patients you do not agree with, they can be coded as palliative care not clinically indicated. I'll show you the code on the next slide. For those patients who've been added to the register, you'd need to create an urgent care plan, which is on the Better platform. But practices will also have to record this on our LTC template too. So for a new plan, practices will receive £200, and any plan that's updated, you'll receive £100, and that would include updating anything that you receive from acute care. But please bear in mind, the payment is only for patients who've been added to the register from April the 1st this year. Of course, patients may decline to have an urgent care plan, and that can be recorded on our template too. But also be aware that excessive exception reporting will be reviewed with the practices. So this is the end of life template in EMIS. The section is at the top of the end of life palliative care page in the LTC template, and it will only show after you have recorded the patient as palliative care in the care record. This red highlighted section is where to record if the care plan has been created, reviewed or declined. And similarly in system 1, this is just a screenshot of how the template looks, where it's located. So just to recap, practices need to run the early tool each quarter. This will generate a list of patients who are considered to be in their last years of life. You then need to undertake a clinical validation of the list. This will be to ensure that each patient is appropriate to be added to the palliative care register. This could be a desktop evaluation of the patient record by any clinician that the practice deems appropriate. Then you can organise a review with each patient, and please remember to include those who might be important to them, so that could be carers or family members. The review can be face-to-face or remote, take into consideration the patient wishes, and this will enable personalised care planning discussions to take place so that preferences and wishes are documented. This is the early tool that we are hosting both in EMIS and in System 1. And again, just a reminder, this is not like our CEG Apple tools. There's no spreadsheet. You won't have to import this data into, etc. Practices will need to run the searches quarterly and access, where it's highlighted in red, the combined list of patients to be reviewed report. And this is where the end of life support searches are. And as you can see, the early identification tool sits within that in EMIS and just above it in System 1. Any questions?
Are there any questions in the chat? We're unable to see the chat.
Yeah, there's a question about use. Obviously, we use Billie-Jo in Waltham Forest, so we duplicated.
Sorry, I think.
Yeah.
Yes, it's the same as the Better. There's another question. Will these be available in the PCN eHub? Is that the template or is that the searches you're talking about?
Yeah, it's very, very massively borderline. So I guess you have to compare it to your own region. Above 60 is not slightly.
So the template will be available for the practices. If you've got enterprise searches, I believe they will be available as well.
But
That's
just that on that one, Jane. So with PCNs, most of them won't have enterprise searches. So we're looking at developing that in the eHealth project. But you're right, you need enterprise to be able to run those searches. If not, it'll be practices pulling the data. You'd also need Valida on the PCN services as well.
yes. And also, somebody's just asked, will we get the 24, 25 CG searches? They're live in Newham now, and I believe, Faye, correct me if I'm right, they'll be live in Waltham Forest next week?
All TNW spec searches are live already in Waltham Forest, System 1 and EMIS.
Oh, okay, brilliant. So they're live everywhere. Yep, they're already available for you to use. Okay, there's no.
Bhupender's got his hand up.
Sorry,
Hi.
guys, I just came late. I missed the entire presentation. I'm feeling really upset. I missed everything, but
No,
quite a few people came late, so I'm so sorry about that. Could somebody show us these searches on EMIS at least, so we know where to look? Because that's the biggest stress I find.
Yeah, so Bhupinder, we've only covered childhood IMS so far, which is just basically your searches in your QOF searches, and the end of life support searches, which you're already using anyway. It's the early tool. And Shamshal should have copied the searches across already, so they are available for you.
Okay.
I've already done that.
Okay,
Yeah.
thanks, Shamshal.
But the end of life, the Valida will be the place where the beans are counted. They're not counted within enterprise searches. Is that right?
Yes, that's correct.
Yeah. Okay. All right. So then, how will we know that we've done the work? Because one of the problems is that you never know if your work's being counted. So will we get monthly reports from Better Care?
Pat, do you know that? But what we're saying to you, Bhupinder, if you code it in the template as well, we'll be doing the report as well. So if you've done it on the Better platform and you also code it in the patient's record, we will be counting that. Which
code will you be using for that? Which search? Because
it's in the end of life template. It's in your LTC on the end of life page. Can you just quickly show Bhupinder the screenshot, please?
Sorry about this. So sorry.
Yeah, it's there.
Okay, and then the review one is there too. Okay.
Yes.
Okay, so one of those two codes, and then we've got to go back into Better Care, because I think the Better Care data is key, because that's where you're doing the payment trigger, aren't you? So we need to have some feedback. I don't want to be told at the end of the year, oh, sorry, you clicked the wrong button and none of your care plans have got counted. Pat, that's quite important. If you could tell us how you're going to do that and get them to give us quarterly reports.
Yes, I can get onto the universal care plan system anyway, so I can confirm that for you.
What would be really helpful if you could show us what we've achieved last year, because I've not seen anything for 2 years now, and I've done loads and loads of universal care plans, UCPs, Better Care, Valida, whatever you want to call them.
Yes,
I've got 3 names for the same thing, but it would be helpful to get some feedback.
I've actually been looking at the figures literally this week, and I've been putting together the figures for the practices. And you're right, you have done a lot.
Oh yeah, well, it's good to know we have, but I don't know if we've clicked the right button.
I should be coming out to you with the numbers.
Yeah. Okay. Yeah, that's really, really helpful, especially because we've got nursing homes, so we do loads.
Okay, shall we move on? I'm going to take you through the high intensity users specification as well now. So what we're going to do is practices need to proactively manage patients who frequently attend A&E. So this is to ensure that patients are seen and treated in the right place at the right time, and this will help support a reduction in avoidable A&E attendances. The PCN practices are to collaborate to deliver outcomes of the scheme. So use a holistic approach, look at the psychosocial needs with coaching and connections to wider support services. So that could be use of care coordinators, social prescribers, health and wellbeing coaches. Practices can identify best practice among GP practices in your network, and then you can use this to support each other and perhaps support practices who are struggling to achieve the outcomes. And there's a variety of methods you can use to support patients. You can have telephone triage, consider same-day appointments, some advisory leaflets, and also self-management. So the requirements in detail here, we will provide support searches for the previous quarter. Practices will need to code the discharge summaries appropriately though. So all GP practices will need to access searches for their quarterly figures. Then there will be a quarterly audit to complete, which will be provided by the ICB. And in this audit, you could consider whether the attendance was medically avoidable. Was the attendance during availability of daytime or weekday walk-in services? What was the background? Was it biological, psychological rather, or social to the attendance? And what actions have been taken to encourage the patients not to attend A&E unnecessarily or inappropriately in the future? But please remember, this is about identifying patients that did not need to attend A&E or the urgent treatment centre. So obviously if somebody attended because they'd broken their leg, that would be quite appropriate. For this review, practices will receive £50 per report. These payments include admin time and everything really to review the reports, to identify those patients who've been attending A&E 3 or more times, and then any follow-ups you need to do to support them in this. And this is the screenshot for where you can find your searches every quarter. They're available for practices both in EMIS and in System 1. So that was a brief look through the high intensity users. Is there any questions?
Yes, there's one in the chat, Pritt. Said, can we have the achievement data via PCN dashboard summary?
I don't think we've been asked to do any reporting on this. So it will just be on your searches.
So this is a practice KPI, not a PCN KPI, just as an FYI. So the way that it's been spec by the ICB is that it goes straight to practices, the high intensity users stuff. So it'll be in your practice dashboard or your practice searches.
And you need to submit the audit to the ICB quarterly for payment.
Yeah.
Yeah, we will be doing searches with dashboards.
And where is the audit paper, or how can we send the audits?
They haven't circulated it yet, so the ICB should be in touch with regards to that. So the first thing the ICB need to be doing is updating the current contracts for practices and PCNs with regards to KPIs and SNSs, and then they will be in touch with regards to how to do the reporting, how to do the claims. It'll be a similar, I presume, method to previous, which is the Excel sheet being updated, but I'm sure Pat or Myra can update us on that.
And is there any codes that we need, the practice needs to work on to make sure that we have achieved or we have reviewed the patients?
So as per that presentation, we ideally in an ideal world, you want everyone to be using one code, but that isn't going to be realistic. So essentially, we try to encompass as many codes as possible that practices are using, with the idea that eventually people use a similar similar code or codes. So there'll be a lot of duplication initially, and we can try and work through that. But the way that the spec's written, we need to encompass all that work. So yeah, it should capture all your discharge summaries for A&E. It may capture too much, but we can always tighten that up a little bit.
Can I ask about the code to actually show that you've done the report? That's not clear.
No, there's no code, Bhupinder. That'll be what you submit to the ICB via the template. So there is actually no code.
So what, EMIS numbers and things will be something to send?
Myra's got his hand up, so it might be good, Bhupinder, if we let Myra answer that. Or he had his hand up. I don't know, Myra, if you wanted to answer that.
Yep. Anything would need to be submitted as a report. The reports will be shared with the practices as part of the framework or contract update. So all of the recommendations are going to be there. However, if practices want those reports, we are happy to share them in advance. No problem.
Yes, I think we need
my camera is not working for some reason. Sorry, apologies.
Myra, I think Bipinder's going to say something, but what I was going to say is that ideally we want everything ASAP as from a practice point of view. So we need the updated contracts so people have the contracts and understand the parameters as well as the reporting methodology for each parameter. But if that's going to take a while, then yes, please do send over what you do have for now. But if an updated email can have everything in one email, because it's quite hard to source framework specs reporting for practices and PCNs otherwise if it's all coming in different emails.
Yeah, happy to send everything out.
Can it be put on a website? You know, your NEL website. Can you put in?
Can't, Bipinder. I've asked that question about 6 to 9 months ago due to the intranet being they haven't got password protection and data encryption, so they've said no. I have asked that question.
There's nothing confidential in the blank reports, is there?
Not allowed under NHS guidance.
Okay.
I've asked the question, Bipinder. I'm with you on this one, but it's been flagged.
Something better than an email. What if I miss an email? I'm on holiday. It's a hard.
You're preaching to the converted, Bipinder. We can take this offline, but I'm with you on this. But
I'll ring you later.
Yeah, that's fine.
Are there any other questions?
Just somebody's asked, is there an ideal period to run the quarterly searches? So I suppose, yeah, just really at the end of each quarter, probably within the week of the first week after the quarter. Yeah.
Okay, so we're going to move on now, and I'm going to cover the simple wound care and suture removal. So the aim of this is to ensure that there's a 5-day wound care service for adults and children, with appointments available to all registered patients within the PCN area. So the main aim is to ensure that that clinically appropriate patients are being treated within primary care, and enables the care and consistent reviews within the primary care setting. The following procedures are included. So it's removal of sutures, clips, staples.
You're not sharing, Billie-Jo? You're not sharing.
I can see it.
Yeah,
I can too.
Yeah, I can.
Rupinder, is it you?
Yeah, it's always me. I'm sorry.
Sorry, carry on, Bill.
So the following procedures are included. So removal of sutures, clips, staples, closed post-op wound dressings, open surgical wounds of a depth less than 2 centimeters, superficial wounds, superficial and superficial partial burns. But please note all burns related to children 0 to 16 should be referred to the urgent treatment centre. So they don't come under this specification. Here is just a table to just go over the superficial and superficial partial burns. So that is there for you for guidance. So as it was mentioned earlier, Newham and Waltham Forest are different specs. So for Newham practices, the PCNs or practices must ensure that they hold at least 2 appointments that can be bookable through the single point access per each day until 2 p.m. Once 2 p.m. comes, they can open these appointments to be booked as general appointments, but the single point access must always take priority for these appointments. So if a patient requiring simple wound care arrives in the complex wound care clinic, they will be advised to contact their practice to book one of these appointments. The data will be, the urgent treatment centre data will be monitored on a monthly basis to ensure that there isn't any appropriate distribution of the appointments across the practices and PCNs for the single point of access to use. So for Newham practices, the payment, so the PCN practices will be paid $13.13 for each procedure, included onward referrals. So it may mean that there's more than 1 procedure per patient. So if a patient comes in and you remove the dressing, clean the dressing and apply a new one, that is 3 procedures. They will also be paid £11.25 for each appointment held. for use of the single point access, whether booked or not, and £4 admin time per patient to cover booking of these 2 appointments. For Waltham Forest practices, the PCNs and practices are not required to hold a minimum number of appointments daily, and the payment for these will be paid on 15-minute nursing time at 13.13 for each procedure, including onward referrals, and also this can be more than 1 procedure per patient. So the template to use for this would be wound care and intramuscular injection template. So for Newham, this is version 4, and for Waltham Forest, this will be version 1. Here is just a screenshot of an EMIS template, and then also for system 1. We've also got support searches available. So for these, for EMIS and for system 1, you will have 2 different searches. So you can see at the top, you've got number of patients recorded with an opened wound, and then also you'll have a opened wound payment search. So the payment search will be looking at number of wound care. So the count of how many wound cares have been done. Are there any questions regarding the wound care?
Just try to answer some of them in the chat, but I'm just going to go through them if that's all right. Just reiterate that Waltham Forest wound care spec has not been signed off yet. It's still going back to the ICB. I envisage it will be signed off. The sticking issue point is meds optimization, ensuring where we get the supplies from and the consumables from. Just going to go through the questions. So Toyan's asked, may have missed, what is the pathway for patients accessing this service? Do they contact the surgery? So wound care is an SNS, so it goes to PCNs, and PCNs you need to offer for Waltham Forest and Newham, if I remember correctly, it's a 5-day service. So it's whether you do it at PCN level or at practice level, that's for you to decide as a collaborative, Toyan. So some practices may want to do certain days, as long as it's a 5-day coverage that fulfills the spec. But again, this is an SNS, not a KPI. Matu, I would probably suggest, if I'll try and find an email and try and get that to you. We have asked a question manual with regards to the differences between Newham and Waltham Forest, and as Pat has replied, it's due to the urgent care need at Newham for those 2 appointments, but the payments, if I'm not mistaken, are exactly the same. Sharon says, if the payments for each procedure, such as removal, dressing, clean wound, etc., does that mean we have to use templates separately each time in the same consultation? No, because there's 3 different procedures are in the same templates. There's 3 different drop downs. So as per the example, if you see a patient, you remove the existing dressing, is 1 payment. You clean the dressing, is another payment. You apply a new dressing, that's a 3rd payment, all within the same template. I think we showed that, or can we show the template again, please? So there you go. So open, it's there. I think it's the slide before, was, if I'm not mistaken, is that the one? Yeah. So open wound, wound intervention, closed wound. When you drop down, you can literally just, where the 2 asterisks are on the wound care, those are the 3 payments, and you can do a free text there as well. And then later in the template, it allows you as clinicians to talk about whether the wound's infected, anything else that you're doing, any further referrals. Bipinda, it doesn't include complex wounds, so the spec is very clear that anything more than 2 centimeters in depth, i.e. something that needs packing, it should not be done under this spec and should be going to the more complicated wound care. So that for Waltham Forest is NELFed. Someone mentioned previously that a lot of this stuff is getting pushed back. Please highlight that to your LMC reps. So for Waltham Forest, it's myself or anyone else on the LMC. Newham, it's Tammy or anyone else in your reps. We need to highlight this so that NELFed understand that they need to be still seeing the more complex wounds. It also is very clear as to things like superficial burns and childhood burns should not be seen at all. So superficial burns potentially looking at the clinician, but childhood should not be seen at all. What if a patient has 2 or more wounds? Then put it through as 2 or more templates. So put it as one for, say, an arm wound, and then a second template again for the leg wound. Treat them as 2 separate incidents. So yeah, we don't do complex wounds. Hopefully that's all the questions in the chat. There was a few hands up. Susanna?
Yeah, sorry. Thank you for answering the obviously complex wounds, which has been a battle over the past few years. We just cannot seem to shift it. So, yeah, I will contact Tammy and let her know. With regards to repeated attendance, it's not reflected when you run the search. And we have seen patients since 1st of April who have seen us maybe 3-4 times for the wound review, but they only come on searches as once.
Okay.
So how do we then? We've done those dressings on 4 different occasions. But when you run the search, they only come as one.
So I think that's something that we need to look at, because that should be 4 different episodes.
Yeah,
You're absolutely
absolutely.
right. So if you can email that to your KEG facilitator so we can have a look at the
will do.
searches.
Sorry, Billie-Jo, can you go back to the searches? Have you got the correct searches copied across? Because we're actually looking for counts of procedures. So can you see on the screen here where you've got 1A? So the number 1 is the actual number of patients who've got an open wound recorded, whereas actually the payment one is how many counts of open wounds have been recorded. It's not looking at number of patients, it's actually looking at the procedures.
Yeah, so I've copied your searches.
If you run this, if you've coded that 4 times on 4 separate occasions, it will pick up 4 procedures for that patient.
Okay, I'll double check. Thank you.
I would say that if you haven't copied it recently, in the last 2 or 3 days, re-copy the searches over from the KEG resource publisher and rerun the search. And if it still doesn't flag it up, then flag it to KEG. But I think what Jane is saying is correct. So it's the payments where in brackets, that's what you need to be looking at.
Yeah, I think Shamshar's got a hand up.
Yeah, I just wanted to let you all know that are you all aware that there is no available appointments for these dressing clinics which are out there for the wounds which needs to be attended. The patients either go in urgent care center or come back to us. So that's where the dressing keeps on coming back to the GP surgeries. So can we make the availability with these dressing clinics more so that we are not ending up doing these dressings? So just wanted to highlight that the dressing clinic never ever have appointments available. We have called, we have sent messages, we have sent referrals, and it gets rejected, and the patients unfortunately have to go to the urgent care centers.
So A, totally agree with your point there. B, it's not something that KEG can help with, but Myra and Pat, I'd probably say that's something for you guys to take away, because it was happening pre-April, before this spec was even launched, where community services were rejecting patients for wound care dressings, and obviously we as practices and PCNs can't have that. So obviously we'll take on what is in the spec, but anything outside the spec, other providers who are commissioned need to do that. Pat, you got your hand up to respond.
Yeah, I was just going to say about the complex care. I'm well aware that, of these. I've gone back literally yesterday as well, had lots of conversations telling the UTC this can't happen. They cannot be sent through to the practices. They must go to complex care clinics, because if they come to the practices, they just need to go back, and it's not fair on the patients. So I'm well aware that that is happening, and I am in conversations with the UTC about them either retaining them for the complex care or sending them to complex care and not out into primary care.
That's Pat. What I would say, Shamsa, is that I've already put this on the agenda for the next NMC chairs meeting for North East London. It's already been there, but we're going to highlight it again because for me it's a huge problem. So it's kind of going away from the KEG issue. So I don't want to focus on it too much because that's more of a commission issue rather than a KEG problem, but it is something that I'm fully aware of.
Thank you, Ashraf. Just wanted to highlight one more thing, that when the patients are discharged from the hospital, there is no plan which is written on the actual discharge for the wounds, what needs to happen. If that can also be taken back while we are taking this forward, so that we can have a proper plan for the dressing and it could all work fine for the patient.
Agreed. Again, I'll raise that at the NMC chairs. Before we bring in Bipinder's looking at the chat again, Imran, packing should not be part of the spec. It's not part of the spec at all. So as much as I appreciate final assignments gets sent, it's not part of this spec. It should be done by, in Waltham Forest, it's done by the Nelf Tissue Nurses team. With regard to, I think there was another question looking through access. It's a 5-day service. The spec doesn't highlight how many appointments you need to offer in Waltham Forest and Newham. Newham is slightly different with regard to the urgent care part of it, but the actual practice of PCN provision is, as long as you're offering a 5-day service, there's no minimum or maximum capacity on there, but on the spec. Do we need to be using certain slot types for these wound care appointments? Is the data extracted? No, the data is extracted, Samantha, via the template. So the template and the searches that you've seen there. Jane, I've answered all that right, haven't I? Please do tell me if I've misspoken anyway.
No, I think
that's all right.
Yeah. Just to clarify, sorry, on the Newham spec, it does say minimum 2 appointments per practice.
For
should
that,
be available,
that's for the, as
it
I
should be
mentioned,
available until 3 o'clock. But we can offer more if the need is there. Then we can offer more, and we will still get paid for whatever work we do and the appointment. Or
so
if that, or
the 2 appointments are so that UCC can book into them in Newham. That's the UCC link there. The rest of the spec, there is no minimum maximum capacity. The minimum 2 appointments is so that UCC can book patients down into those specific slots.
And then we will still get paid at the same rate as it's on the spec.
Yes, that's right. Yeah.
Okay, thank you. Yeah.
Are there any other questions?
Well, I got my hand up.
Oh, sorry, Bhupinder, I can't see.
Can I talk now, Asa?
Yep.
Is that okay? So it's more for Pat and Miro. Because there's not been enough capacity at urgent care centres, our staff are doing packing and have been doing so for some time and doing complex wounds. Some of them take 40 minutes. Now we've got a highly trained skilled workforce who've been doing this because there was a demand and a need. And under our old spec, we thought that was covered. Now it's been taken off, which is the right thing to do. So I'm not disagreeing with my GP colleagues or LMC colleagues who said, no, it's not included in the spec. I'm wondering if the commissioners would create a new tariff for complex wounds with packing, because I know the UTC doesn't have capacity. So these poor patients are going to get caught between a commissioning deficiency or a lack of capacity at the UTC, because we'll just end up sending all these patients back and there'll be a queue and there'll be complaints, and we will then end up doing these wounds because I don't think we've got the heart to say goodbye to these patients. So Pat and Miro to consider that.
Okay, thanks, Bhupinder. Sanjay, you got your hand up?
Yes, I mean, I echo what Bhupinder is saying, really. So a lot of my point was already made by him. So we have patients who will come straight to the surgery, not necessarily via UTC. So what happens to them? Can we still do the claim, or does it have to be referred by the single point of access?
You'll get paid for doing the wound care, Sanjay, if they come straight to you. The 2 appointments are for the UCP to book in. It's if that patients go to them and they need referring on to your practice. But any of the wound cares you can still do within your practice if they turn up on that day.
Okay, and we still get paid in the same way using the template?
Yes, yes.
Okay, okay, that's great. Thank you.
Okay, so I'm going to move on to the T Today programme. So this is a NEL programme. It's an extended consultation, which is 30 minutes for people with type 2 diabetes under the age of 40. This is £52 per adult, which includes clarification of the diabetes type. So they should be reviewed to make sure that the type is correct, that's recorded on their records. And if you think that they are any concerns, you should refer them to the specialist, or if they're type 1, then they should be referred urgently onwards before doing, and don't do any review. Preconception advice, optimization of glycemia, cardiovascular risk and weight. So if there is any need for statins and SGLT inhibitors for the cardiovascular risk or weight, should be consider a referral to the T2DR program, and any other referrals for exercise or signposting to parks for the exercise as well. Also, assessment of well-being and social needs. So if they do need a referral to the social prescriber, or if there is any other services that are indicated, then these patients should be referred on to them, and depression screening. So the rollout of the programme is across NEL. It started the 1st of April. With Waltham Forest, the extended consultation is for all type 2 patients aged 18 to 39 years. And for Newham, it's 18 to 25 will be under secondary care, and 26 to 39 will be seen in primary care. Anyone under the age of 18 obviously doesn't fall under this category for this extended consultation. So the template, so the extended consultation is located in the LTC template under the diabetes page. It will show at the top if these patients are eligible, as we're put on a visibility rule for these patients. And the clinicians are expected to mop up any 9 care processes that are missing at this extended consultation as well. So this is the template. So you must tick the diabetic extended appointment follow-up for payment to be processed, and then it will go on to optimizations, assessment, preconception advice. And then here you have support searches for these as well. So you can see here you've got your System 1 and your EMIS support searches. And within inside these support searches, you will see recall. So obviously it will show different. You won't see both of these. It depends which area you are with. So for Newham, for example, it will show recall searches for 26 to 39 who are eligible to have the extended consultation. And then the support search for Newham would be aged 26 to 39 who have received an extended consultation, and then a quality indicator report. So you'll only see one in each. Are there any questions regarding the Tea Today programme?
I think Kay had a hand up. She's got her hand down. She's been leading on this as well. Don't know if Kay, you wanted to add anything. No? I think, okay. Kay, did you want to add anything from your perspective? You had your hand up previously.
Yeah, sorry, I thought it was missing the 8 care processes, but I think that's the last slide out there.
I'm sorry, Kay, I'm going to interrupt. I can barely hear you. I'm not sure if that's everyone.
Maybe that would help.
Much better. There you go.
Okay. No, I was going to say I've got nothing else to add. It was just the fact that I didn't think it included the 8 care processes, but I think there was a slide later to say if there's any outstanding 8 care processes as part of that extended review, you need to kind of do those bits as well.
Yeah, that's correct.
Yeah, and just to reiterate, this is a national program, not a local program. So yes, NEL, I've worked on it with a NEL template, but the funding comes from national. We've got the funding for this financial year, and we're waiting for clarification. It was a 2-year program. We've got starting last year nationally. We've got funding for this financial year, and we'll see whether or not we have funding for the following year. That's still to be confirmed. The numbers, depending on your practice, really. So per 10,000, the average is about 30 patients per 10,000 patients. This size is, so it's not huge numbers. So yeah, just as an FYI.
While we're doing questions, I'm just going to put this up in case anybody wants to find out the contact details for the local facilitators. We can still take questions if there's any more.
So I'm checking the search on my EMIS, which I can't share. It's got patients' names on it. The 8K processes seems to be not the normal ones. They seem quite different, and there seems to be 11 columns. So can somebody clarify how that matches up to the spec? Because you're saying that we have to get all the 8 care processes for every one of these reviews. So we've done 8 reviews or 11 reviews. Not a single one has hit the 8 care, or in fact 11 columns. So it's got other things as well. So who can clarify that for us?
One of the things you probably have to see Bhupinder to be able to understand exactly what you're doing. I was logging onto my EMIS.
It
I'm not logged
says,
on to see.
I'll read it out to you. It's got Q risks.
Not going to help with it. Read it out. I'll be honest with you. These searches, it's always easy to visualize. Let's just see.
Where it's talking about health literacy, housing discussed, financial discussions, loneliness recorded, social service, so refer to social prescriber, PHQ9, preconception advice if appropriate.
Bhupinder, are you looking at the template itself?
I'm looking at the quality indicator report for age T2, age 26 to 39.
Yeah, so that is the requirements that it includes Bhupinder, but also the clinicians are expected to mop up any 8 care processes that are missing at this extended. So that is the extended consultation that you just read out. That is what's required for that. And then but clinicians are expected to do a mop up of the 8 care processes at this appointment as well, if anything's missing.
Yeah, Bhupinder, that report is a quality indicator. It's not for payment, so it's a guide. It's just a guide to see what you've done. You'll actually be paid. They might not necessarily need all of those things completing, and it's just basically a guide to see how you're doing with the quality of the extended consultation. Does that make sense?
Yeah, it makes a lot of sense. Can you add the 8 care processes as another search under that same group so that we can check it at the same time? Otherwise, we'll have to add it ourselves. Quality, yeah. Is that possible?
Yep, that's fine. I can do that for you. Okay.
Yeah.
Yeah.
Thank you. Thank you. It's all in one place then for us to check.
Yes.
Thank you.
No problem.
Hi. So these patients will be in, you know, the SNSs. How am I doing? The diabetes, you know, in the diabetes folder, these patients will be in there as well, isn't it?
Yes.
Yes, that's correct.
Okay. All right. No problem. So this year, we have been raising with ICB that we are doing 7 to 8 indicators, and for one indicator we don't get payments. Like we just the urine ACR is the major one. Is there any updates on there that will we get paid? Like if we miss one indicator, or we still have continue doing that? We have to complete the 8 and the 9 indicators.
So the LTC review contract has been rolled over by the ICB. So the indicators for the LTC, the only slight changes that I'm aware of, and Kay, you may be better placed than I, is the asthma question is now ACT only and the COPD is CAT only. All the other indicators are the same, Kay, or am I misspeaking?
No, you're absolutely right. The only other one that I actually heard that I may remove, well, I'm trying to remove, is the depression screening as part of the asthma one, because I think it's not very meaningful and it's quite difficult. So that I've sent you an email today. I said you'll have to pick it up today.
That's fine. I'm glad I heard that. But the diabetes one, in answer to your question, sorry, I don't know who was answering the question. The indicators have rolled over.
So we will still be scrutinized as practices for doing everything right and the patient not doing one indicator where you're chasing them. And literally, I think we have to go and sit in the toilet with them now to do that. That's what the last thing result seems like for practices.
So as a GP partner and as someone who works with the LMC, I understand what you're saying. What I would say is that I know that, Kay, what's the company now that are doing the ACRs?
Healthy IO, but that's only in Waltham Forest and not in Newham.
So, okay, so I'm glad I asked you first. It's a question to ask the commissioners, to be honest with you, with regards to how to do that. Now, what we need to remember is local enhanced services, you cannot exclude, because that's the difference between things like QOF and the local enhanced services. But it's a question to ask probably Myra and Pat rather than KEG. Again, KEG are not there to design the specs. They're there to help support the specs with searches and templates. So they won't be able to have that conversation. Any other questions?
So if that is the case, that is there any funding which is available so that the Newham can have?
Again, the wrong forum. This is not the forum to discuss contracts from a commissioning perspective. KEG
Yeah,
aren't
but then
designed
we are
for that.
discussing something with the CEG, with the 8K processes. So we just need to find out if the processes are being done at the GP surgery. We are calling and recalling patients. We're just putting it out there. We're not asking you to give us an answer, but at least something which is here. And whoever is then listening or can take this forward can look into it, please.
So the
the
way
question.
forward is the LMC who negotiate the contracts with the ICB and speaking to the likes of Myra and Pat. It has been raised. It definitely has been raised again and again and again. And at the moment, because of a lot of different things, the LTC framework has been rolled over. A lot of suggestions have been made as to adjustments to that. I'm with you. Like I said, I'm a practicing GP 5 days a week, so I know exactly where you're coming from with regards to UNACRs. We've also struggled. But those points that you make are perfectly valid, but have been raised in the right forums.
That's fine. Thank you.
Any other questions regarding searches, templates? Just as an FYI for everyone, we are working, or KEG are working on adjusting the templates with regards to trying to make it a little bit more user-friendly. We're open to feedback, but it's whether or not we practices would prefer certain things. So I think there's a few practices that are on the KEG list with regards to trial practices, so we'll be trying certain things over the next few months. But all the searches are live as per phase update. Okay, anything you want to add?
Just a reminder to all practices, especially in Waltham Forest. I don't know about Newham because I don't cover Newham, but if you sign up to the SNS, you must use the CEG template to record your information. If you're using Ardens or any other template, you won't get paid. So just a word of warning.
Thank you.
Yeah, so you have to free code those codes. It's better just to use the KEG template for the LTC stuff. Absolutely. Jane or Pritt, was there anything else?
No.
Jane, anything?
No, don't think so. I'll just update the 8K process in the T-Today programme searches just for ease. Yep.
Perfect. And thank you for sharing this last slide. So again, everyone who doesn't know who their local support teams are for KEG, it's all on this slide. Visits are still happening. Get in touch with regards to any difficulties you're having with searches or any challenges or any improvements. KEG are really receptive to feedback. And like I said, all searches are live. If there's no more questions, we can bring this webinar to a close.
So we will send out a feedback form as well that will come with the presentation slides as well.
Perfect.
Okay, just a final request, because this last year when we submitted something, we submitted everything to manual submission, like reports and stuff. We submitted to now email, and we were asked then to submit to TNW email. So it'll be good on the submission templates, manual submission templates, to put the emails where we need to submit this.
I agree. And Myra, I believe you can take that back. It would be good if we didn't have to do manual submissions, if I'm being brutally honest, and if the searches were sufficient, if they're picking up the work so that ICB can do the right payments. For those where the searches are there, I appreciate some things like high intensity users do need manual submissions, but if we can have everything correct on this email circular, Myra, that'd be great.
It's on there.
Brilliant, thank you. Any final comments or questions?
Can we invite you to at the PCN meetings to again, or is that a big ask?
Who specifically? Asking Jane, Pritt, KEG?
Not necessarily yourself, but if we can invite KEG and maybe Pat to come along in Newham.
Yeah, we're happy to attend.
Happy to attend.
Yeah, we'd
Okay.
be very, very happy to attend all of your PCN meetings wherever you need us.
Yeah.
Thank you. Thank you.
Okay, that's The webinar's finished now. Like we said, we will send out the slides as well, so you'll receive them shortly with a feedback form. But thank you all for attending.